Good morning, everyone. Today, in our FRCS Urology Viva teaching series, discussing the intermediate and high risk and also metastatic prostate cancers, we have our trainee. Thank you for the trainee for agreeing to record this session. We should be available in YouTube for others to revise and make sure that it is revised again and again to get the maximum information useful for the exams. Okay, you are doing your normal weekly oncology MDT. Your patient is 72-year-old, is fit and well, no comorbidities, no family history of prostate cancer. He has minimal urinary symptoms with IPSS of 10 and quality of life 3. He had prostate biopsy for his increased PSA of 9. It showed Gleason 3 plus 4 prostate cancer occupying 4 out of 34 cores. Previously, his MRI showed PIRAD 5 lesions. What are the options for him?
Considering he belongs to intermediate risk prostate cancer, his options are radical prostatectomy, radical radiotherapy, and these are the preferred one, but he can also opt for active surveillance, and he can have brachytherapy as well.
Why do you opt for active surveillance? What criteria you will look for?
For active surveillance, I will look for preferably the patient should be in low risk group as far as NICE guidelines are concerned, and but for the Royal Marsden inclusion group, this also this fits in in the group which we can do, because in Royal Marsden group it is the age should be between 50 to 80 and patient fit for the for any treatment, radical treatment, and PSA less than 15, clinical stage of the disease T1 or T2, and Gleason's score, as you said, it is 3 plus 4, and the positive core biopsies should be less than 50%.
Okay. So this patient had MRI of PIRAD 5. So few things are pointing towards intermediate risk, and you have given the options. Patient opted for radical options, and he doesn't want to wait with active surveillance. Does this patient require any further staging?
Yeah. So the patient will need further CT scan to rule out, I mean, first of all, to rule out any more chances of lymph node through the thorax, abdomen, and pelvis. And the chances of bony metastasis are very low. And so after that, then we would be, we can proceed. Sorry, I couldn't understand. Is the question any further investigations or?
Yeah, any further staging investigations?
A bone scan is very less likely to find anything, and in this case, CT, thorax, abdomen, and pelvis should be the one next investigation.
Why do you think bone scan has less chance to find any mets? What is the evidence or data behind it?
This is his PSA is only 9.1, and with this, because he is in intermediate risk group. In this group, the chances of bony metastasis in intermediate is less than 5%, only 2 or 3%.
Okay, his PSA is 9 as you said. PSA makes him low risk category. For low risk disease, the chance of bone scan positivity is 2.3. If the PSA is between 10.1 and 19.9, the chance of bone scan positivity is 5.3. And for PSA more than 20 up to 50, the chance of bone scan positivity is 16%. So because of the less chance of finding bone mets, there is no role for bone scan. Again, for CT scans, there is no real strong role, especially for CT thorax. Your MRI is good to show the pelvic mets. If there are no pelvic metastasis, this patient doesn't require any further staging. How will you counsel this patient for radical options?
I will explain him both radical prostatectomy and radical radiotherapy, and I will explain the pros and cons of both procedures with the surgery that we have got the advantage of getting rid of prostate totally, so the chances of recurrence are minimum. And but on the other hand, the chances, the side effects of surgery sometimes can affect his decision making. On the other hand, the radiotherapy, it can treat as well, but it has got different side effects. So then it will depend upon him to decide after having this discussion about both.
Whenever you are discussing radical surgery and radical radiotherapy with a patient, make sure that you will try to do it in a joint clinic in the presence of clinical oncologist also.
Yeah.
You also should include the presence of the oncology cancer nurse specialist. You can use that. You will use BAUS information leaflet to inform him about both the radical options. What is the evidence behind radical prostatectomy?
Evidence is basically about because we know this, the patient can have it's a radical treatment, and also because the previous researches the one which was done in the past, but those are basically for comparing both this active surveillance with the radical treatment for basically for the low growth like clots as well as the PROTECT trial and the SPCG also, but these are more in favor of active surveillance. For the radical treatment, then the evidence is nice guideline basically.
Okay, but if you look into the studies, SPCG study included low risk and intermediate risk population, and it showed radical prostatectomy as clinical cancer specific survival up to 80.4% at 23 years. It's a little bit old study. It happened between 1989 and 1999, but you can show the latest studies like PIVOT study and PROTECT study. PIVOT study included low risk and intermediate risk groups showing cancer specific survival 95.9%, and PROTECT study, which included screening population also mainly of low risk and intermediate risk groups, showed cancer specific survival 99% in 10 years for radical prostatectomy. So there are good studies to prove that radical prostatectomy has good clinical cancer specific survival.
Right. Yeah.
How will you counsel this patient for radical prostatectomy?
I will counsel him with the help of BAUS information leaflet, and will explain him the benefit of the procedure and the risks as well, and then get him ready, explain him about both the pros and cons of the procedures, and get him ready for the procedure.
Okay.
Any side effects I need to mention now?
Yeah, how are you going to plan? What type of radical prostatectomy you are going to plan for him?
So I will explain him first of all. The procedure can be done as an open operation, laparoscopically, as well as robotic assisted laparoscopically as well. And I will also explain what is the experience of the center to do the procedure. And but I will also tell him that all three ways to do the procedure have got equal oncological as well as functional outcome. But laparoscopic and robotic have got the extra advantage that the procedure is done under higher magnification, so the structures can be seen more clearly. But definitely I will tell the experience in our center and how many procedures we have done, so that the patient can decide himself.
You also need to discuss about the pelvic floor muscle treatment so that he is getting enough physiotherapy, and you can introduce him to support groups also. Support groups has the patients who had previous radical prostatectomy, which gives an idea about the patient, about surgery, post-op period, etc.
Right.
How will you explain the side effects of radical prostatectomy robotic assisted?
Well, I will explain him the side effects in the form of immediate side effects, which are during the surgery as well as immediate post-operative period, and then the late side effects. The immediate or side effects could be anesthetic related as well as surgery related. Anesthetic risks are about 5 to 10%, and which are could be chest infection, deep vein thrombosis immediately after the procedure or during, and the pulmonary embolism as well as risk of myocardial infarction. And the risk of mortality will tell about 0 to 1 or 1.5%. And then significant infection or bleeding each can be 5 to 10%. And then the rectal injury also can be about 4 to 5%. And then I will also explain that the chances of urinary incontinence initially after the procedure, next few weeks or months, could be significantly up to 50%. But the late complication, I will tell, with the help of pelvic floor exercises, the urinary incontinence should improve significantly, and lately it can continue in 5 to 10%. And also erectile dysfunction, which is also around 50%.
Okay, you can use the BAUS information leaflet. The values are slightly different. Erectile dysfunction could be up to 80 to 85%. Mild urinary incontinence 10 to 20. Severe urinary incontinence 3 to 5%. You need to include chances of positive margin 2 to 10%. You can use the nomograms for that. You can include the need for possible hormone treatment or radiotherapy or chemotherapy in a later date, 2 to 10%, and rare possibility of open conversion, 1%.
Right. Yeah.
Is there any role for adjuvant treatment prior to radical prostatectomy?
No, there is no role of any adjuvant treatment before the prostatectomy.
That's good. Previously, it was believed that it will reduce the positive margin, it will lower the incidence of positive lymph nodes, but there is no evidence to that. How will you explain the patient between robotic vs lap vs open?
Yeah, I will explain him about the benefits and the drawbacks of each procedure, explaining him about the robotic procedure has got relatively less chances of urinary incontinence and erectile dysfunction. And while in case of laparoscopic procedure, the side effects more or less could be same, but laparoscopic procedure is available more easily in more centers as well. And I will also explain that both procedures have got the advantage that during the surgery there will be magnifications and structures can be more clearly, so damage to other organs could be possibly reduced, and but the chances of infection or bleeding are more or less same. But the most important would be to tell him what facility is available in this center, and the patient likes to be referred for, especially the robotic procedure is available only in few centers. So if he liked, then we could refer him to that particular center.
You need to mention that there is a significant difference and no significant difference. Regarding no significant difference, there is no difference in oncological urinary sexual function outcome. Regarding the statistically significant difference, we can say duration of hospital stay and blood transfusion are better for robotic or lap assisted prostatectomy. What do you think about lymph node dissection? Do you think our patient need it?
He is in intermediate risk group, so he needs lymph node dissections in the form of extended lymph node dissection.
So do you think intermediate risk group patients require extended lymph node dissection?
Yes.
Okay. For intermediate risk group, there is no real advantage in doing pelvic lymph node dissection or even extended. There is no difference in the oncological outcome or survival. Lymph node dissection comes into play only for high risk disease. We can use the nomograms like Biganti, Partin, MSKCC, or Roche formula. If the risk of nodal metastasis is over 5%, there is a role for lymph node dissection. As per EAU 2021 guidelines, it is increased to 7% because we are using MRI targeted biopsy, which tend to upgrade the Gleason score. Is there any role for frozen section intraoperatively?
No, there is no role for frozen section. It used to be in the past, but it's not being done now.
Any role for radiotherapy? How will you plan radiotherapy for this patient? Patient, after hearing all your explanation, decided not to go for radical surgery because of urinary incontinence and problems with the erection.
Yeah. So I will then explain him about the radiotherapy, also using the BAUS information leaflet, and preferably I will arrange his meeting with the oncologist, also with the same clinic with me or as a separate clinic. And I will then explain that the procedure of radical radiotherapy as well as the brachytherapy to him, and explain him and the procedure as well as the side effects of both of them.
What are the types of radiotherapy available?
This is the external beam radiotherapy, which is currently intensity modulated radiotherapy. And the other one is brachytherapy, which is either low dose rate or high dose rate.
And also proton therapy. Don't forget that.
Okay.
So, what is the dose for intensity modulated radiotherapy?
Traditionally, as approved by the NICE guideline, it is 74 grays to be given in 37 fractions, 2 grays each time. But after the CHIP trial in 2016, it is recommended that he can have 60 grays in 20 fractions, which have got the equal effect.
Very good. Nice quoting the evidence and correct doses. What are the contraindications for external beam radiotherapy?
Contraindication generally or any previous pelvic radiotherapy, any significant low urinary tract symptoms, and also inflammatory bowel disease.
Very good. What is the role for androgen deprivation treatment in a patient going for radiotherapy?
Androgen deprivation, as for explained by the BOLO trial, that it reduces the chances of positive, should not say positive, but basically as a long-term survival is improved if it is adjuvant radiotherapy is given. A NICE guideline has added that radiotherapy new adjuvant 3 to 6 months starting, and after that as an adjuvant to continue 2 years post-operative for intermediate risk. And for the high risk, if it is for 3 years, a high risk or locally advanced diseases to continue, then survival is improved, biochemical recurrence is improved as well.
Good. For high risk people, if we have androgen deprivation treatment continuing for 3 years, as per EORTC trial or Bollard et al., disease-free survival is 74% versus 40%. Overall survival is 78% versus 62%. Okay, what do you know about brachytherapy?
Brachytherapy is the form of radiation which is given locally in the prostate, and it is of 2 types, high dose rate and low dose rate. Both have got their own advantages and disadvantages. High dose involves iodine 125 or palladium 103, and while high dose involves iridium 192. And in case of low dose, basically these are the seeds which are implanted through the perineum and transrectal ultrasound guided and placed there, and the seeds remain effective for next few months, and they can slowly provide about 150 grays of radiation. But the disadvantage would be that other family members could be affected by radiation, and especially children in home. He should keep the children away from him and should avoid normal sexual intercourse, but he can have a protected one. And the high-dose brachytherapy, which involves iridium-192, in which, again, the under general anesthesia and through the perineum, plastic tubes are inserted, which are placed there for few minutes, and radiation can be effectively completed within a few minutes. And the disadvantages of the other one for seeds to continue for radiation for next few months can be avoided.
Okay, what are the side effects of high dose brachytherapy?
Side effects would be, I mean, the side effect, basically, though the side effects for both of them will be like cystitis as well as urinary, urinary incontinence, urinary retention, and these side effects will be as a whole longer duration for continuing for the low dose. For the high dose, they will continue for only for few weeks, basically. Same as erectile dysfunction as well. But possibly the second cancer in the future, that is maybe higher.
Okay, and it's also cause significant bowel disturbances or bowel related side effects.
Bowel disturbance. Yeah, that's right.
Okay. This patient underwent radical radiotherapy with neoadjuvant treatment planned for say 6 months because of his intermediate risk. Post-operatively, his PSA increased to 13. So what is happening?
PSA increased to 13, and it means the disease patient has got. What was the immediate the PS minimum PSA, which is nadir PSA? What was the level?
He haven't reached the nadir PSA, and post-operatively the PSA is increased. What do you know about the PSA bounce?
PSA bounce is a benign rise of PSA after the radiotherapy, this conventional external beam radiotherapy as well as brachytherapy. But this PSA is benign, and usually it happens around 9 months to 1 year time, and but it should not increase more than 1.5. This PSA is significant rise PSA, so it does not fit in the category of PSA bounce.
Okay, very good. What is the role for radiotherapy in a patient who is undergoing radical prostatectomy?
The role of radiotherapy in this scenario is for the recurrence of disease after the surgery, and that is a local recurrence. So that if after the surgery, if PSA is more than 0.2 nanogram per milliliter from the nadir, in that case, then a radical radiotherapy need to be offered.
Say, for example, our patient is undergoing radical prostatectomy and it showed positive margin. In that case, is there any role for radiotherapy?
With the positive margin, uh, there, there is some controversy between NICE guideline as well as EAU guidelines. In the NICE guideline, it is not recommended immediately for radiotherapy, and the recommendation is to continue with follow-up. And if PSA rises, but it's still less than 1 nanogram per milliliter. In that case, that should be offered. But EAU says that it can either be offered immediately after we have found the positive margin, or it can be given as a delayed, but still it should be, even if it's delayed, it should be after the PSA rise of 0.5 and before 1. The figure we should give that one.
You can bring in Radical's trial. Radical's trial's conclusion is there is no difference in disease recurrence at 5 years if the man is going for radiotherapy immediately after prostatectomy or radiotherapy later if the cancer recurrence happens. How will you follow up this patient who had radical prostatectomy?
After when the patient will be discharged from the hospital, I will arrange for him to have a trial without a catheter in about 10 days to 2 weeks. And then I would like to see him in the outpatient clinic in 6 weeks from the surgery. The object of that visit is to, first of all, to explain him about the histological diagnosis, and as well as to assess for any complications from the surgery and his improvement from the surgery as well. And also, this is the time which is appropriate to explain him about the 5 PDE inhibitors to commence in order to improve erectile function, and also to explain and to continue the pelvic floor exercises to minimize the chances of urinary incontinence.
Okay. Any role for PSMA PET scan in the follow-up in case if the PSA is raising?
No, after that, then I will arrange another appointment in another 6 weeks, mean 3 months from the surgery with the PSA. And that PSA, from there onward, if PSA has come down to nadir, then further follow-up will be every 6 monthly with PSA.
Okay. What is the role for PSMA PET in the post-op follow-up if there is a PSA increase?
If PSA increases, then depending upon this, ideally the PSA should be repeated earlier in next 3-4 months again. And if as previously Astro guidance, this is the 3 consecutive rise of PSA from the nadir, and these PSA should not be more than 4 months apart, and the mean of these is just kept as a midline, like in between the period, and that is the level which will tell us about the recurrence of disease. But with the newly Phoenix a classification system in that it is the one which is PSA should be any PSA rise 0.2 nanogram per milliliter from the nadir.
Yeah, I don't need to mention the previous criteria. You can say that persistent increase in PSA more than 0.2 nanogram per ml shows like biochemical recurrence, and you will be offering PSMA PET scan. Okay.
Right. Thank you.
Is there any role for any other investigations if the PSA is increasing?
Depending upon the how much PSA is rising, the patient can be offered for the PET scan or PMS PET as well. And but if the PSA is significant rise of PSA, then we should arrange the MRI again as well as the bone scan, and complete staging will be with the CT, thorax, abdomen as well. So depending upon in the context of PSA, how much high it is.
If the PSA is in the region of say 0.2, 0.4, the CT, MRI or bone scan is not very sensitive. So PSMA PET is the only sensitive investigations available. Now we have finished the intermediate risk prostate cancer. Can we have a different scenario? Is it okay?
Yeah, that's okay. Thank you.
Okay. A patient with a PSA of 32 and examination showed bilateral nodular prostate amounting to clinically T3 if not T4. The patient had prostate biopsy which showed Gleason 4+5 prostate cancer occupying 3 out of 10 cores. Only limited cores were done because he is definite prostate cancer. His bone scan showed at least 3 to 4 areas of bone metastasis, and CT scan showed presence of pelvic lymph nodes. What are you going to do?
This case looked like metastatic prostate cancer. So then he does have minimum possibility, minimum options, and the main stay of treatment in this scenario is hormonal deprivation therapy. And also he can still, he can have watchful waiting, but the disease is already metastatic. So he should be provided with the information of hormonal treatment and commence for that, and also need to explain him about the initial start of the chemotherapy upstage. The patient looked like a more fit patient, and he could get the benefit from the upfront DOCETAXEL and along with hormonal treatment.
Okay. What hormone options are available?
He has got the option of hormonal deprivation therapy, mean he can have surgical orchidectomy, medical orchidectomy. These are the main, but he can also opt for only anti-androgens, but these are less effective.
What do you mean by medical orchidectomy?
Medical orchidectomy means either LHRH agonists or LHRH antagonists.
Okay. So what is the agent you will give to this patient?
The agents LHRH agonists are either goserelin or leuprolin.
Mm-hmm.
and LHRH antagonist. Its name just came out of my head suddenly.
Digarelix.
Digarelix. Yeah, thank you.
How will you start the LHRH agonist injections?
I will start him initially with anti-androgens in the form of bicalutamide 50 milligram a day, and after a week of bicalutamide, then I will give him injection of gozerelin, and then the bicalutamide need to continue for another 2 weeks afterwards.
Why are you giving bicalutamide?
Because the LHRH agonist given initially, they can stimulate the GnRH receptors in the pituitary to increase in the level of LH and testosterone, which can flare up significantly in the next few days of commencement, and to reduce the chances of that flare up.
What happens during flare up?
The most catastrophic consequences could be spinal cord compression, but the other conditions can also happen, like ureteric obstructions, severe bony pain or backache, or acute urinary retention, as well as some other like more hepatotoxicity or this can happen.
It can even cause hypercoagulation status resulting in cardiovascular death.
Thank you.
Okay. You said about docetaxel. What is the evidence for upfront docetaxel in this patient?
There is one trial going on, which I forgot the name.
Okay, there are two trials which supported upfront docetaxel with ADT in newly diagnosed metastatic carcinoma prostate, Charted trial and Stampede.
Stampede, yeah.
At least Stampede you should be able to bring in.
Yeah.
How will you give docetaxel chemotherapy?
Docetaxel is given 3 weekly basis, 3 weekly for 8 to 10 cycles.
It's usually 6 cycles, 3 weeks apart, and it's an intravenous infusion. How docetaxel acts?
It does act by the microtubule polymerization. So is disintegrates the microtubules in order to prevent the cell to replicate.
Okay, very good. Disrupts microtubule array. Okay, so now our patient initially responded well to docetaxel and also the androgen deprivation treatment, and you are continuing the androgen deprivation treatment. His PSA behaved for 2 years, and then the PSA is showing increase. What is happening?
Son, no, it looks like that he is developing castrate resistance. It's a hormonal treatment or not effective look like in this situation.
Okay, so how will you define castrate resistant prostate cancer?
It is the it could be any combination of either persistently increasing PSA or aggravation of any metastasis, or the presence of new metastasis despite being on hormonal treatment.
Okay, so any radiological progression, you can use the RESIST criteria, which is response evaluation criteria in solid tumors. As per that, either 2 or more new bone lesions in the bone scan or any soft tissue lesion. The other one is biochemical progression, where there is 2 increase in the PSA above nadir, 50% increase in the PSA above nadir, and PSA is more than 2 nanogram per ml. The PSA increase should be at least 3 consecutive rises and PSA test done 1 week apart. What is the value of testosterone in these patients?
Testosterone will be within a normal range of less than 50 nanogram.
Yeah, regarding dose, you need to say less than 50 nanogram per deciliter, nanogram per dl. So what are the options available for a patient developed CRPC?
So the patient is generally in the fit group, then if he did not have chemotherapy or abiraterone before, he can be commenced for that one. But before that, he can have maximum androgen blockade in the form of addition of anti-androgens, mainly the start of bucoletamide, and also the other treatment can be given like estrogens or steroids.
The options available, or if the patient haven't had docetaxel before, he can have docetaxel. When you are saying abiraterone, include prednisolone also, enzalutamide, cabazitaxel, olaparib, and iridium 223. Okay,
Right.
you're on call. Your general medicine registrar on call colleague has called you to help with the patient. Patient is 63-year-old, presented with paraplegia, and his PSA was 1300. And the paraplegia evaluation, they have done MRI of spinal canal, which showed metastatic cord compression, possibly due to prostate cancer. How are you going to treat this patient?
I will immediately involve in the care of this patient without any delay. And after having a diagnosis, I will just ensure that the patient is treated without any movement from the bed, and he should be strictly on the bed. And I will immediately commence him on high dose steroids. And also then, as already bone scan has already been done, so he had, sorry, I couldn't hear that. Did he have the MRI done?
He had only MRI done, bone scan not done.
So I will arrange the bone scan as well, and to see his generalized, his bony metastasis as well. But he needs to be treated urgently with steroids. And also I will explain, I will also speak with the regional center for spinal trauma for the urgent decompression, as well as I will inform our oncologist for the possibility of radiotherapy, localized radiotherapy as well.
Okay. What is the immediate medication you will be giving him?
Immediate, I will give him steroids, high dose steroids.
What steroid? What is the dose?
This is steroids.
Okay, you'll give
dexamethasone.
Dexamethasone loading dose of 16 milligrams, and you will continue 16 milligrams daily. It has to be continued till the patient is getting stable, whether the patient getting radiotherapy or decompression surgery, and then the dose is gradually reduced over 1 week. along with proton pump inhibitors, since dexamethasone is quite a gastric irritant. So other things you can consider is GnRH antagonist, as we discussed degarelix, which will help in the control of the prostate cancer part. Patient also needs analgesics, bisphosphonates, radiotherapy, surgery as needed. Very good. That's a quite detailed discussion. We have discussed the intermediate risk prostate cancer and high risk prostate cancer. We have touched upon metastatic prostate cancer, biochemical recurrence, and metastatic spinal cord compression. Well done. You could only improve further from here, and I hope in next few weeks, especially with the BAUS course coming ahead, you will further improve your knowledge and theory background, and you can present much confidently. Any feedback from yourself before we complete?
No, that's fine. I think I heard this one. You explained the all steps very nicely, and whichever things I missed, you just told me in much more detail, and that's very good addition to my knowledge as well. So I will continue on this line as per your advice for the future as well.
Very good.
Yeah.
That's very good. Now, good hard work from there, and then you can nicely build up from this strong basement so that the answers are more complete, more evidence based, more values, especially for prostate cancer and BPH tables. Very good.
Yeah.
Have a good rest of the weekend, and I
Thank
hope
you.
the next week, the busy BAUS week, going good and very informative for you.
Thank you very much. Are we doing this one graduate tomorrow or not?
Tomorrow we have another trainee doing. If you want, we can do next week, Monday to Friday, any day, if you are comfortable.
But next week will be BOS course. No?
Yeah, so we'll do after the BAUS, okay?
After the BOS, yeah. Then I mean, whatever the days are available.
I will send you a message. We can do after the BAUS, yeah.
Okay. Thank you very much.
Bye. Have a good day.
Thank you, and you. Thanks. Have a nice day. Thanks.